So welcome everyone. My PhD thesis is the accuracy of digital technology in implant prosthesis from impression taking to cast fabrication. My name is Boldizsár Vánkos. I'm a second-year resident at the Department of Prosthodontics and a first-year PhD student at the Center of Translational Medicine. Currently, I have three topics. I would like to talk about the first two in details. The third one is an in vitro trial, which is still in the planning phase. And the first two are systematic reviews and meta-analysis. So the first topic is comparing the accuracy of additive versus conventional cast fabrication in implant prosthodontics. I started this project in September, and I'm planning to finish it in June. So when fabricating an implant prosthesis, one of the most important factors is that the implant analog in the cast should be in the exact same position as the implants are in the jaws. To achieve this, dentists most often use the conventional method, which means taking an open tray impression and pouring it with gypsum. This is considered to be the gold standard in implant prosthodontics, but it has its drawbacks. It's time-consuming, it's labor-intensive, and since it's done by hand, the quality is not constant, and there are many possibilities of error. Additive technology can be an alternative to this, which means using intraoral scanners and 3D printers to create the definitive implant cast. It's much more time and cost effective. It can be partially or fully automated, and it produces a standard constant quality. But this is a novel technology, and the accuracy is still under discussion. So my aim is to investigate the accuracy of additive cast fabrication compared to conventional method in implant prosthodontics. To answer my clinical question of accuracy of additively manufactured implant casts, I plan to use the PICO framework. My population is going to be dental typodonts with implants. Intervention is additive cast manufacturing, and the comparator is conventional cast manufacturing. The outcomes would be 3D and linear deviations of the analogs in micrometers. And my hypothesis is that additive cast manufacturing in implant prosthodontics is at least as accurate as the conventional method. Clinical implications of this project could be producing standard quality prosthesis, enhancing lab communication, and simplifying and accelerating the workflow. I conducted my systematic search in 3 databases, yielding a total number of 3,568 studies. And after the selection, I have 9 eligible full text. The next step is the data extraction, which I'm working on right now. My second topic is comparing the accuracy of conventional versus different digital implant impression techniques. I started this project in November, and this is also going to be a systematic review and meta-analysis. So the gold standard implant impression technique considered to be the open tray implant impression technique, for which the splinting of the copings is advised, and dentists most often use some high quality polyether or type A silicone impression material. This is a complicated and lengthy procedure which is unpleasant for the patient. It requires a long setting time for the impression material. It's not always feasible, for example, in rehabilitational prosthodontic cases. And of course, many mistakes can be made. An alternative to this could be digital impression taking with classic intraoral scan bodies or with coded healing abutments. In this case, there is no pain, no discomfort or less discomfort for the patients. There is no setting time, and it's a much simpler, quicker workflow. But in this case, as well as in the previous one, the accuracy is a big question. So my aim is to investigate the accuracy of different digital implant impression techniques compared to the conventional open tray method. In this case, I also use the PICO framework. The population would be patients and dental typodonts with implants. There would be 2 interventions: digital impression taking with scan bodies and digital impression taking with coded healing abutments. The comparator would be conventional open tray impression taking, and the outcomes would be 3D and linear deviations of the implant analogs. My hypothesis is that digital impression taking in implant prosthodontics is at least as accurate as the conventional method. With these findings, we could reduce discomfort of the patients, reduce time spent in the dental chair, and we can solve special anatomical situations, for example, rehabilitation and prosthodontic situations. I conducted a preliminary search with the search key, and the total number of hits is 2026. There are two previous meta-analyses of this topic. Both of them is, so one of them is 2 and the other one is 4 years old. And they are also a bit more limited than the one I am planning. And there is no other meta-analysis in Prospero, just systematic reviews. So I would like to end my presentation with a quote from Antal Szerb. As long as we keep moving, we don't notice how tired we are, but only when we sit down. And thank you for your kind attention.
Yes, thank you for your presentation as well. Regarding your second project, do you have any timely cut-off which types of digital impression you would include? I could imagine that digital impression machines 15 years ago are much different in their accuracy as they would be today. So do you consider all digital impression machines for it, or only the ones from 2010 onwards or so on?
Well, thank you for your question. Right now I'm still working on the topic, so it's not certain yet. One thing for sure is that I would only include full arch digital impressions. And for the time limit, we haven't decided yet, but of course it's very important to follow the trends in this, because 1 or 2 years can also mean a big difference. So maybe the past 10 years, the past 5-10 years would be a good start.
So still regarding the impressions, we know that impressions are better in time with experience. So even if we talk about digital or analog, so my question would be, how would you deal with, for example, an unexperienced practitioner who takes the impression versus an experienced one who takes it? Because usually there is a big difference between them.
Thank you for your question. Yes, sure, there's a big difference. In the studies that I've read, they usually don't consider this, or it's not mentioned in the materials and methods section. The in vitro trial that I am planning is also in connection with impression taking and scanning. In that case, I would be the one who takes all the impressions, and I would be the one who makes all the scans. And that could be kind of like standardizing the process.
Congratulations for your great presentation. My question is, for your first topic, what would be the exact method to compare the analogs in the gypsum cast and in the resin 3D printed cast?
Thank you for the question. There are three main methods, but 2 of them is used in these studies. One could be measuring the casts and the position of the implant analogs with a mechanical machine. It's called a coordinate measuring machine. The other one would be rescanning the analogs with a high accuracy laboratory or industrial scanner. And after the rescanning or the mechanical measuring, the files could be superimposed to each other, and the deviations could be measured in a CAD/CAM software.
Yeah, thank you for a nice presentation. You have quoted one article which says it's faster to use the scanners than use the normal, yes. Original techniques. Is it related to a single implant impression or several ones? Because I guess if it's a full arch, as you said, you are going to investigate the full arch, might have several, let's say 6, 7, and between teeth. For scanning, to me, it seems a bit challenging, so I'm not sure if it's faster really than just taking a conventional impression.
Thank you for your question. Of course, this also depends on the situation, and this also depends on the physician or the dentist who's doing the impression or the scanning. In my experience, in single implant cases, it's much quicker. In multi-implant cases, it's a different scenario, but I also read articles that younger generations who who kind of start their career with scanning. The scanning is quicker, but for the older generations who started their career with the conventional impression taking and got very used to the conventional method and new to the digital method, for them the conventional method is usually still faster in these cases. So it depends on the practitioner a lot, and also on the scanner and also on the impression material. So a lot of factors.
About your first topic, what are the references for the 3D and linear deviation? And if you already know, how is this homogeneous between the articles that you included? Are they different? Did they use different references for that? Are they homogeneous or not?
Thank you for your question. They used the superimposition method in all the articles, so in that case it's homogeneous. The results themselves are very different as far as I remember, so it's going to be interesting to see the reason behind it.